My name is Ingrid van Klooster. I live in Zutphen in the Netherlands. I'm married and have 3 children. I'm actually Canadian and I've lived here for 15 years.
My name is Jolien Pon. I'm a cancer patient from 2008, colon cancer, and I live in the Netherlands.
The problem started during breastfeeding my youngest child. That's already 7 years ago.
I went to my family doctor to have a normal checkup, and I told her that I had a strange feeling in my belly.
It was just not right. It was painful, and long after I stopped breastfeeding, after about a year, it didn't heal. There were problems.
After 2 weeks, I had terrible cramps in my belly. It was unbearable.
So I saw my doctor, I saw a lactation consultant also during the breastfeeding, and eventually ended up having a mammogram, which showed nothing, an MRI scan, which also didn't show anything, and it turned out it was right in the nipple itself.
The surgeon told me that they had found metastasis in my lymph nodes.
I was diagnosed with M. Paget's of the nipple. Totally blown away. And one of my first reactions was, my family is so far away.
So I got the message that I was going to die. In my head. It wasn't told that way, but that was the message I received in my head. And I was very numb. I didn't know what to think.
And it turned out that it was also in my lymph nodes in my armpit. 5 of the 11 had cancer in them. That meant that I would have to have chemotherapy. Before the operation, they thought maybe we could get away with just radiation. About a month after the operation, 4 sessions of pretty heavy chemotherapy, from which I got quite sick.
I got oxaliplatin. I had a lot of side effects. I had everything they said might happen.
12 sessions of lighter that I didn't get so sick from. Tired, but really that was quite doable. Began with something called Herceptin, and that went on for a year. That was every 3 weeks, and then somewhere in there, 33 sessions of radiation.
We have today a large number of powerful cytotoxic drugs, some of which have a very gentle safety profile. And we have also witnessed the development of a large number of agents that target the HER2 receptor. So for women with HER2-positive breast cancer, we have seen really very important, significant improvements in survival.
Breast cancer surgery has changed tremendously over the past 30 years. It came from radical mastectomies all over the place to breast conservation, and now the lymph node axillary conservation. And this has huge effects on the quality of life of breast cancer survivors.
The trials that I've been involved with in Europe on breast cancer treatment. In the first one, we had a survival rate of 65% at 10 years. In the second one, the so-called BOOST trial, we have a survival rate of 80%. And now the most recent one here in Holland that we have performed with 2,400 patients, we have now a 5-year survival of 95% and only 1% local recurrence rate.
Nowadays we have imaging techniques that can visualize receptor expression. So if we have specific imaging probes that can tell you, is this cancer expressing estrogen receptors, is it expressing the Herceptin receptor? And by doing this we provide extra information for the clinician to select the proper treatment.
The surgeon told me that they had found metastasis in my lymph nodes. I got oxaliplatin.
With the systemic treatment, we have made clear progress in colorectal cancer. We have different cytotoxics, we have different targeted agents today. With the optimal use in the optimal sequence, we can improve the outcome of patients, we can improve the survival of patients. Moreover, in some patients, the optimal use and the optimal combination can lead to conversion of not resectable to resectable disease. and this can cure some patients.
20 years ago, in 1/3 of all rectal cancer patients, the cancer recurred in the pelvis, giving a lot of complaints and usually untreatable. Nowadays, it's less than 5%. Also in colon cancer, the results of surgery have improved. There is now approximately 40% of patients in the Northern European countries, because we have good information of those countries, are treated laparoscopically rather than with open surgery, so that the in-hospital stay is shorter and the inconvenience is lower.
For colon, radiation oncology has really a marginal role. But for rectal cancer, it is part of the core group of treatment that we can offer to the patient. Radiation oncology can help the surgeon to eradicate tumor from the pelvis and also to contribute to the improvement of survival. In the last years, radiation oncology was the main driver of an organ-saving approach. 1 out of 5 patients with the locally advanced cancer can avoid major surgery or not receiving surgery at all, because the response of the tumor after the treatment is impressive.
There's a huge number of people that I met, nurses and doctors and specialists in the hospital. I felt they communicated quite well with each other. I didn't need to fill them in between.
Nurses are very much involved in multidisciplinary teams in some countries, and there's a lot of evidence that if you have nurses in multidisciplinary teams, it improves outcomes for patients.
We all understand the potential contribution of the individual disciplines so that we can select the best treatment for an individual cancer patient.
What I think will happen pretty soon is that we will also need to interact with geneticists because of the increasing knowledge we will have about the cancer genome, but also the patient's genome. We will need ethicists to join. We will need a closer interaction with pathologists, given the complexity of the molecular screening we are going to perform for cancer patients. So it's going to be an even bigger challenge than it has been until now, but it's crucial. It will be crucial if we really want to reach the goal of personalized oncology.
What I very much would like to say to the professionals: do share your knowledge with your patients, so that your patient can become a partner in sharing decision making. And what I also would say, please, when you come home, do share it also with the patient organizations, if they are in your country, or the self-help groups. I think when we work together, it will be much more better in the end.
Physicians and the paramedical team should engage with the patient, should have a certain level of empathy, because the different decisions are in oncology not always black and white.
We have to engage them in the same passion that we have for identifying what are the key values, what are the best organizational aspects that we have to use to translate and to transfer evidences in cure. And finally, to find a room for emotions.
The central issue in the ECCO organization is that every patient deserves the best in Europe. And how can we know that the patient gets the best, and how can we improve that?
It was life-changing, but I don't think my life changed. And what I mean by that is, I didn't all of a sudden, after I was finished, completely change everything in my life and do things differently. I'm still doing what I was doing, but my outlook is a little different.
I have more pleasure in simple things. I enjoy being at home and see my children and see my grandchildren.
I was already positive, but I think I'm even happier with just a nice day, with just normal things going on with my kids, and it doesn't have to be too exciting.